We've evolved from what was really a very simple, typically a single disease process, single retinal image, 35 to 50 degrees, depending on the camera, to now what is almost a complete eye exam that can be performed.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Serare Ziai and myself, Dr. Guillermo Rocha.
This season, we have two new co-hosts joining us, Dr. Mona Dagger and Dr. Hadi Saheb. They'll be hosting upcoming episodes throughout the season. Season 3 of the EyeCan podcast is brought to you by Bayer Ophthalmology. Thank you for your support.
On this episode of EyeCan, we're excited to introduce our listeners to the topic of tele-ophthalmology with guest Dr. David Maberley, head of the Department of Ophthalmology at the Ottawa Hospital. After completing his residency at the University of Toronto, Dr. Maberley undertook a retina fellowship at Queen's University, where he also completed a Master's of Science in Community Health and Epidemiology. Following his training in Kingston, he studied macular disease and advanced retina surgical techniques at Columbia University and the Manhattan Eye, Ear, and Throat Hospital in New York City. Recent undertakings include the establishment of the collaboration in the Epidemiology of Ocular Disease, which is a big data pharmacoepidemiology research group that works collaboratively with industry and government, and a co-leadership role with the Diabetic Retinopathy Goal Group of Diabetes Action Canada.
Currently, he's working with the Technical University in Eindhoven in the Netherlands, assisting with validation and safety work on PrecEyes ophthalmic surgical robot.
Welcome to the EyeCan podcast, Dr. Maberley.
Thank you, David, for being with us today to share your experience and knowledge about telemedicine and how it has changed how we practice ophthalmology. David, you have decades worth of experience in tele-ophthalmology, whereas ophthalmologists only took it up by necessity during the pandemic. Can you tell us what is tele-ophthalmology? Can you describe it in simple terms?
Yes, thanks, Mona. It's nice to be here, and it's great to be here with you and Guillermo. Tele-ophthalmology, I think, in many ways is an evolving area, and it's hard to pin it down. What it was 20 odd years ago is not what it is anymore. We started with tele-ophthalmology. Really, it was based around retinal fundus photography in the early ages of digital photography, when that was just coming on board. We had 1 megapixel cameras. Some of the early work, for example, when I was in Kingston, Alan Crewis and I flew a digital camera up to Moose Factory in Moosonee on James Bay, and we took photographs for a week of hundreds of patients up there who had diabetes, and we recorded that onto what were actually sort of advanced floppy drives, brought the data back down to Kingston at that time and read the images and then reported back to the communities. We did a lot of validation work at that time. We were also examining at that time, but it was more of the process and learning how to build that process. That was early tele-ophthalmology. It was retinal fundus photography on big cameras with very rudimentary quality digital imaging, where we were just trying to look for anything that looked really, really bad. And that was sort of the goal, trying to pick up those severe pathologies that were very likely to need laser therapy at that time. Zoom ahead now 25 years, almost 30 years from those early cameras. We now have gone from just diabetic retinopathy screening to screening for glaucoma to screening for macular degeneration. We have added optical coherence tomography to our armamentarium, very high resolution stereo imaging. Was sort of one of the early developments, and that allows for optic nerve assessments now and glaucoma nerve head assessments. And there's now work happening. Some great work has been done in Kingston with Martin Tenhove and his group on using slit lamps and this sort of thing to actually examine the front of the eye. So we've evolved from what was really a very simple, typically a single disease process, single retinal image, 35 to 50 degrees, depending on the camera, to now what is almost a complete eye exam that can be performed depending on the service that is providing the service. But the capabilities and the instrumentation is now very evolved, and we can do so much more with such higher, I would say, quality in terms of our interpretability. And that now includes AI to use used in that setting for interpreting images. So that's where we've come in the last 25 years, and it's a massively expanding, exciting field even now, and we're going to see huge advancement in the near future too.
Yeah, we've really come a long way. What do you think are the advantages of teleophthalmology, and what are some of its disadvantages?
Well, I think an example of the advantages we've kind of seen during COVID, where we have had difficulty reaching out to patients, not only in remote settings, which is sort of where teleophthalmology really had its nascence in reaching remote communities, typically First Nations, Indigenous communities with high rates of diabetes, often was the sort of starting point, to a setting where we've had to adopt to providing care remotely. And it's difficult in ophthalmology. We haven't had the same sort of success perhaps as other subspecialty areas or specialty areas in medicine, where you can do more of an assessment on a simple camera and a Zoom call, for example. But I think many groups have started to incorporate more teleophthalmology as a result of the COVID experience, and we're trying to get more cameras into communities, and we're trying to get more advanced imaging devices more broadly out there. So the advantage is that we can provide a degree of assessment remotely that we couldn't provide before. So you don't have to travel, the doctor doesn't have to travel necessarily, and the patient doesn't have to travel. And so there's an economy of scale with that is improved. And that ultimately is the advantage. Or at least the primary advantage as I see it. There's other secondary advantages I think we can talk about in terms of cost savings potentially and these types of things. The disadvantage, I think, ultimately comes down to, we're all physicians. We provide care to our patients, and there's something gained, I think, in the completeness of an eye assessment, the full completeness of an eye assessment that we can do in person over a telemedicine assessment. Now, we're getting close to that now, but I think ultimately that is something that we have. Also, the doctor-physician relationship is very important, and as we move remotely to more, I would say, typically in ophthalmology, we are tending to run a technician-based photography services and imaging services. So there isn't that same doctor-patient relationship necessarily in these programs that provide teleophthalmology. And I think potentially things are lost there. And there's just the risk. We know that there's a percentage of teleophthalmology imaging that may be inadequate. We might not be able to get the images we need to provide the patient with the diagnosis. We have to fly patients down when things actually are normal, or we might miss patients when things are abnormal. It's not that can't occur in a face-to-face examination with a patient, but I think the risk might be higher when you're providing that sort of service and you think things are okay remotely, but you're not 100% sure. Whereas in a patient face-to-face, you may have an ability to perhaps more accurately assist your imaging service to find images where perhaps they wouldn't be able to remotely. And you may have more technical skill with your imaging group in a large center and things like this. So I think it's a matter of what we can do. Teleophthalmology is significantly better than nothing. It's leaps and bounds better than nothing, but it may not be quite as good as you can do in a tertiary care type center, and that's understandable. But we're gaining so much more by getting there and getting some sort of assessment in these remote sites. So that's the benefit, really.
Oh, it's great to have you on this podcast, David, because I remember for the longest time, you've always been involved with these types of projects and sort of public health related projects in remote locations as well. So it's nice to see how it's also coming down with technology at this point. As Mona said, during the pandemic, many of us started hearing more and more about teleophthalmology, and it kind of is one thing that it could be a little bit esoteric for the average ophthalmology in an average practice. We hear a lot about synchronous versus asynchronous teleophthalmology. We hear about collaboration with optometrists. So could you give us kind of like what is the most basic way a general ophthalmologist can get into a rudimentary type of telemedicine, an intermediate one where you're collaborating, and then, of course, the last one that I think you've already alluded to a little bit with artificial intelligence and help with interpretation. So kind of, distinguishing between those two concepts of how we deliver teleophthalmology and then how we can get in at those three levels.
Yeah, I think that's a great question. When I just think about sort of the rudimentary level, I think we have some examples of that out there right now that we can refer to that might be an example for people where there's some very reasonably priced camera/AI systems that are currently, for example, Orbis is functioning in northwestern Ontario with a technician delivered small portable camera going into remote communities and doing imaging and reporting immediately based on the AI reports of these cameras to the client or the patient in that setting. Very rudimentary, the report is simply whether there's something that basically needs further follow-up or a degree of retinopathy perhaps, and depending on which software as you get it usually cut off that we're more than, let's say, moderate non-proliferative disease, or you're less than that, and that's sort of the level that you would get from those very rudimentary systems. And those could be purchased, for example, for an ophthalmologist in perhaps a smaller community, and there's no reason that a technician couldn't function on behalf of that ophthalmologist and take the camera out into the field to remote communities and do that work, and then have the positive tests come back for more detailed digital review and then appropriate triage. As you move up from there, I think realistically, the biggest challenge is not the technology or necessarily the false negatives, false positives, which we're always going to be dealing with. It's the program organization, and it's how you are going to organize a more detailed or involved program than just simply having a technician in the field taking pictures, perhaps at a remote office for you. The issues are around funding and sustainability. Does your province have tele-fee codes for teleophthalmology? How many communities do you want to go to? Are there issues in terms of accessing those communities if they're Indigenous? Do you have the buy-in from the community and the band, for example? And then you need sustainability funding. You have to, if you're going to have people up in the community who are up in these communities taking images, how do you fund them? And then how do you read the images that need to be read and report back to the people? Who do you report back to? Who's going to take charge of the results in those communities and make sure follow-up is completed? It's actually more of an administrative challenge, really, these days than a technical challenge. The instrumentation is out there. The devices are available. As you expand beyond maybe a single site teleophthalmology type setting or a small program, for example, we have a small research project right now in the inner city here in Ottawa at one of the community health centers. And it's very easy because it's a single site. The nurses know who to call when they have a problem with the images. We've got a very easy referral pattern to the hospital and the Eye Institute. So it's a very simple A to B. The docs at the Eye Institute, we have residents read imaging and fellows. So the cost is sort of absorbed there. And the volume is small enough that it's not a lot of extra effort. But the second you begin to scale up, the second you want to go to the 10 community health centers here in Ottawa, or you want to reach out to multiple remote communities, now all of a sudden, who's paying for the gas? Who's maintaining the cars and the trucks that are needed to move the devices around? And this is where the intermediate type programs it's more logistics. And again, larger programs for provincial programs become really challenging just from that perspective. You need to complete the loop. You have to have a way of taking those images, reading them. And again, you can start with AI, but that's not going to pick up everything. And you're going to have to review a significant number of images that are inadequate quality or that are just false positives and negatives and things like this. You need to know your sensitivities, specificities as well of your program. And so you end up in this challenge is that who is going to coordinate that? Who's going to make the patient appointment for those that need it? Who's going to find the travel grants? Who's going to fill the forms out? Who's going to make this sort of thing happen? And I think those are the big challenges as you move from simple to complex teleophthalmology. It's easy enough to add, let's say, an OCT device to a fundus camera. Once you've built in your systems and you train your photographers, it's not that complex to add a second device. The issue becomes what software are you going to use to read the OCTs on your platform? How are you going to transfer the images down? These types of things. It becomes much more logistic related in terms of complexity. So I think really the complexity is not so much device related, even though we're adding many devices and adding complexity from the examination side point. That tends not to be technically a challenge. The challenge is the coordination.
Yeah. And do you think the government is at a stage in across Canada where there is enough support for that? Is there enough interest that has been garnered, or is there great variability and we still have a long way to go?
I think there's great variability. Canada has a more siloed healthcare system than I think almost anywhere in the world. It's like we have 10 mini countries, each of which are running their own health systems, as you know, and everybody on this call will understand. And that's the challenge. For example, when I was in BC up until recently, there was no fee code for reading a telemedicine image. And yet, for example, one province over in Alberta, they've had a very robust consultation funding program for their tele-ophthalmology for over 20 years, where a tele-ophthalmology assessment was viewed and funded like a consultation, which was what it was in that time and still is. So this is the challenge. Much has changed over COVID, and there have been some breakthroughs around funding of tele-ophthalmology assessments and this kind of thing, but it's very province specific. And to be honest, when we formed the Diabetes Action Canada, which is a patient-oriented research group about 7 years ago, and most provinces were represented, and many of our ophthalmologists and retina specialists across the country were very involved in supporting that effort. The initial goal was to have a pan-national registry with images and research built out of that platform. But it was very, very difficult to operationalize. And it was very difficult. Governments within the provinces of the country don't like sharing their data. They don't like their data going out of house. And very much, appropriately so, many of the Indigenous communities are in an environment where they own and want to keep control of their data, which is completely appropriate. I think 30 years ago, there was perhaps a history of a bit of a loss of control by those communities over their data and things like this. So I think that's been recaptured, and there's a sensitivity to that now that we have to be aware of. So these large sort of, concept, like in Scotland, where they have the entire nation under a single telemedicine screening program for diabetes, that's a different environment. They're able to do that. And again, perhaps more like a province in terms of size and population than actually a country compared to Canada with, 3 million people in Scotland. I don't know the exact population now, but it's demographically not as big. So we're missing that, and we're not there yet, Guillermo. And I think that's something that I'm not sure how we're going to get there. We have to work provincially, I think, and build out the systems provincially using best practices that have already been developed across the country and trying to implement those in places where we haven't got them implemented. We don't have to rebuild the wheel. Like, we've got great people who have done amazing work in setting up what a telemedicine program looks like in many different places across this country. We've been leaders in this area. We just need to find a way to start sharing that data and sharing best practices. And I'm not sure how we're going to get there ultimately, but it may end up just really good programs, and each province would be a great start.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
I'm Dr. Nitin Chowdhury, and I enjoy listening to the EyeCan podcast on a regular basis.
David, can you tell us what are the risks of using tele-ophthalmology?
Yeah, thanks, Mona. I think we touched on a few of the risks. I think the biggest risk is there's two risks. I think there's the risk. The one that I'm always worried about is the patient interprets a tele-ophthalmology assessment as being a full eye exam. And that's the risk we've had from the very start, where you've taken some photos of the posterior pole and of the retina, and you've got a sense there's no diabetic retinopathy, and you've reported back to the patient that the pictures look good. They could have a sense that their eyes are fine. and all you've really done is a very cursory, it could be more than cursory, but all you've done is a photograph of the retina, and you may or may not have an ability to assess the optic nerve. You may or may not have an ability to assess the peripheral retina in any way, shape, or form. Even with, let's say, you were using a wide-angle imaging system, such as an Optos. So that's my worry: is the patient thinks they're clear. They may have visual symptoms. They may have a problem that they feel has been addressed, and they've been told it's normal, but you need that communication piece. It's very important that the patient really understands it's not a complete eye assessment. That's the first thing that's a risk, I think. The second risk, I think, is obviously, the false negative group of patients for all these different tests where we have pathology that we've missed, or we've not been able to, appropriately diagnose advanced disease. I think that's rarer and rarer. I think the quality of our imaging is getting better and better. So that's a concern. I think the costs in general are, we've got good data showing the benefits, but there is cost. And I think the problem is, I think our costs get sort of focused around the cost of the technology, or not the cost of delivering the full program like we talked about before. And so it's sort of the risks in not really understanding the full breadth of the service, whether it's at a patient level or what the service actually is providing. I also worry a little bit that when we talk about telemedicine in general, tele-ophthalmology, we need to be aware that ultimately it's only as good as the quality of the interpretation. And this is where the AI piece gets a bit concerning as we move into these new directions, is that it's hard to understand exactly, what the AI algorithm is working on and what it's producing in terms of its outputs and things like this. And I think we have to be, as we move forward, be a little bit careful in where we let that go. I don't know what will happen. I think the basic screening is reasonable. It takes physicians potentially out of the screening piece. It may help that way, but it's not necessarily a panacea. And I think we still need good oversight and quality reviewing of images through all of our AI type platforms as they evolve over time. And it's becoming a muddy field too. There's so many different platforms out there. There's so many different AI providers and things, so many different cameras that they work off, so many different algorithms, that I think we still need our hands in this as physicians. We still need to be overseeing this and making sure that we're doing quality assessments so that we know that we're still part of the process, and we're still making sure that we're moving this forward in a safe way for people. So these are the sort of things that I think we're worried about right now. But again, still a great benefit for so many people overall that I think the benefits significantly outweigh the risks, and the risks are falling all the time. So I think we're probably in good stead as we move forward.
Sounds promising.
Excellent. David, you've alluded to the fact that many provinces already have established successful programs across the country. And I guess my question is a two-sided question. One is, what are maybe one or two key features that make a program successful? And the second one is, in these programs across the different provinces, we often think about tele-ophthalmology as far, but if we think about other underserved populations, I have begun to hear about clinicians being very concerned about inner city populations as well that may be marginalized. So I guess the question is, maybe one or two features that make a successful program, and then how is this being applied to not maybe so far, but to taking care of the marginalized populations which are closer to us, but simply not well served at this time?
Yeah, those are great questions, Guillermo. In terms of features of success, I think you need to view this as a collaboration. I see that really important. That was the key piece and again, right now I'm going to sort of specifically talk about some of the remote Indigenous work that we've done in BC through the years, is that you need community buy-in. You need the community to be in charge of the service. So when we were running the BC program, and it's still running successfully, the key is that as ophthalmologists, we actually didn't run the program. And that was the best decision we made at the very start. We had the Carrier-Sakaami First Nation actually take on the administrative role and take on the ownership of the program. And we were consultants. We provided the imaging cameras, we provided the training, we provided the support structures and the infrastructure to report back to them. We did all the data collection and this kind of thing. But we didn't know when Community A might be out on a large community hunt. And, you know, we could have shown up at that community with cameras and nobody would have been there. And we also, we weren't selling the program to the Indigenous communities up in northern BC at the start. They were selling it to each other. And that sort of collaborative buy-in, I think, was key. And that's what made it successful. The other piece we did, too, that I think was really interesting around success is that we decided to provide more than just retinal screening for diabetes. So we had nurses up there with us who would do foot screening and testing for neuropathies. We had point of care labs on site, so we could actually do A1C and lipid testing on site. And the nurses that accompanied this, we worked with Keith Dawson, who's a great endocrinologist in Vancouver. And Keith would actually tinker with people's meds and work with them on their diabetes control at the same time. It slowed our throughput a little bit, but I think we were viewed as really a holistic service that was very, very valuable to these communities because you were providing this really comprehensive endocrine and diabetes complication care piece. We also had education. So the nurses at the end of the day would give classes about diet and exercise and things like this to the people that attended the clinic. So those are the sort of things you can create out of the nidus of, let's say, a photography program. You can build that, make it so much more. So that's sort of success that you can do, build the community in, make it more than just like, it's great now. It's not just that you can go one of two ways. You can kind of go the way of, okay, we're going to make it sort of a holistic diabetes program, or we can make it more of a holistic eye program, and you could throw in a few more anterior segment photos and make it a little bit more, maybe do an autorefraction, maybe do a pinhole visual acuity with your visual acuity, do IOPs, try to get stereo fundus nerve shots and things like this. You could sort of build out sort of more of a comprehensive eye assessment, or you go the other way and build out more of a comprehensive a diabetes program. But both those sort of, so the buy-in of a community and then building out something as an add-on, I think, is a great way to build success. In terms of underserved populations, absolutely. This is where I think the need has been there all along. You know, my work in Vancouver in the downtown east side started sort of in the mid of the HIV challenges and the growing homeless population down there in Vancouver, sort of 25 years ago almost now. And it was interesting, you know, we go down there and we see people who had diabetes. We worked initially out of the Vancouver Native Health Society. That was at the VNHS. And we found that people who lived literally 4 or 5 blocks from 2 or 3 optometrists had never had an eye exam, for example. And they might be a 10-minute walk from St. Paul's Hospital that had a really vibrant and successful eye clinic. And so we realized very quickly to reach this population, again, highly vulnerable population in terms of mental disease, addiction, sex trade, trauma, diabetes, chronic disease, like all the factors that play into significant risk for visual complications. And even just being down there and refracting people was huge, you know, because you can't manage a pair of glasses or contacts down there most of the time. If you're a -5, life is really difficult. So but that's sort of what got us started. And then I think we've now realized that this is more than just, let's say, an inner city Vancouver problem. I think it's more of a, as we for example, in Ottawa, there's a huge unmet need with our recent immigrant population here, which is a different population again entirely. And many of their issues are not the same as the inner city in Vancouver, for example. There's that same population here for sure. But the issue there is often these individuals might be working 2 or 3 jobs. And the only time when they could come to get their eyes assessed might be at awkward times where they could drop in and there might not be a doctor there, et cetera, et cetera. If you can have a standing camera in some of these drop-in community health centers, then when the patient is able to come in, you can still provide them care, even if there's nobody on site who is a trained ophthalmologist or optometrist, et cetera, et cetera. So it's providing a service, not just remotely, but at times and in ways that is more available to the people that are there. And the availability is the same for the inner city underhoused and homeless population, is that the availability is that the service is in their community, where they often built into methadone clinics or built into that sort of a setting where they will be there anyway, and then they can just walk next door, have their eyes imaged, et cetera, et cetera. And that was where we ended up with our clinic in Vancouver, initially with the Vancouver Native Health Society, and then transitioning into Vancouver Coastal Health, basically a methadone drop-in type center where we were able to catch larger percentages of the population.
Okay, great points. Thank you.
That's really wonderful to be able to deliver to so much varied and different populations. Can you tell us what is being offered in tele-ophthalmology, and what are things that we probably will only dream of, or maybe it may happen only in the future though? What can we do in 2023 with tele-ophthalmology?
Well, I think we touched on some of the things that we can do right now, and I think the short-term benefits I think will really come around. I think incorporating more OCT, I think that gives us a lot more comfort in our assessment of all macular pathologies, AMD. We can deal with a lot of the uncertainty around diabetic macular edema. We can do OCT nerves and pick up really, much more valuable information there than just with a stereo photo. And yet it's still relatively easy to capture those images. And some of the systems out there have both sort of a combined color fundus OCT functionality in a single device. There are also, where OCTA fits in will be interesting into this. If we continue to improve the imaging quality of OCT and OCTA, and the ability to get OCT angiography images will be super helpful. If we can start to do, let's say, point of care sort of a single device, really high quality, detailed, wide field OCTA imaging, I think that'll be a huge benefit, especially in our diabetic population. I like the idea of incorporating more wide angle imaging in general, Optos type imaging, where we can start to see more peripheral pathology. We know that there's so many, anterior segment devices, Mona. You could probably do a tele-ophthalmology setup with 6 or 7 different types of pentacams and various imaging devices. You and Guillermo would know more about that. But there may be a way of incorporating anterior segment scanning and corneal imaging, and why would we not necessarily be doing axial length measurements and corneal topographies and keratometry at the same setting if that can be added onto a system very cheaply? It'd be great information if someone comes in, because we test visual acuities in most of our tele-ophthalmology programs. If someone's 20/60 and the retina looks pretty good and you don't have a lot of haze from possibly a mature or maturing cataract, well, why are they 20/60? They've got glasses. Maybe the glasses are wrong. Can we actually do some refractive work remotely? Autorefractors would be great to throw into the mix. So in the near future, I see just more of a holistic and a higher quality assessment. And it's really a money. It's an upfront money thing, and the portability of new devices is getting better and better. So I think we'll add carefully. Certain programs will add certain things in a certain way, but ultimately, I think our ability to do that really complete eye exam is not that far around the corner. In terms of dreams, where we're going to be, well, some of my work has recently been in robotics and working with the PrecEyes team, and that kind of remote potential comes with robotics too, which is the pie in the sky. I think the opportunity to functionally operate procedurally remote from a patient in a tele-ophthalmology environment, and we know that could be done literally now with this particular system. You could very easily set up you need somebody on site to set up the robot, but wouldn't have to be skilled in actually doing the surgery, for example, and could monitor the patient in an OR, perhaps remote to where the surgeon is based, and provide minor procedures. You could even have a functional robot to remove a corneal rust ring. You could have a robot that could ultimately, there's a couple of robots coming down the pipe in the next few years that may be able to do cataract surgery. So these are the pieces that are the ultimate next steps to be able to perform surgery on Mars with a robotic system remotely. May never be possible because of the surgical lag tied into actually transversing the speed of light. So we've talked about that a bit at the site in Eindhoven, but I think there are distances over which you will be able to do remote procedural care and this type of thing using teleophthalmology.
Even vitrectomy?
Well, vitrectomy is actually the first one that's available right now. It's actually the only one that is actually operational and may be coming in the next few years commercially available. So keep your ears to the ground. Yeah.
That's impressive.
I like when you say that we're including more anterior segment stuff. I think Mona and I are in favor of that.
Yeah,
well, this has. Sorry,
I'll leave that to the two of you to figure out.
Awesome. Well, this has been a great conversation, David. I think you've given us a lot of concepts and ideas and sort of imagination opportunities as well. And as we come to the end of each episode, we also like to ask our guests about some of their non-professional activities. So perhaps you can fill us in some of your non-work related activities, books or sports or things that you like to do in your downtime.
Yeah, no, a lot of administration at the hospital and the university level right now. Love to get on the bike, spend a lot of time with my family, my daughters, got lots of activities and I like to be there and supporting her in those right now. We're currently, my wife's taken a brief break from her work as a medical education scholar and has turned away from her PhD and is taking a diploma in horticulture. So we're spending a lot of time thinking and talking about plantings up at our cottage and things like this. So that's going to be a new direction for I think both of us. But
awesome.
These are the kinds of things. There's never enough time in the day, you know.
Well, excellent.
Thank you so much, David, for sharing all your expertise with us. It was really enlightening to listen to all that you've done. Congratulations on all that you've accomplished in teleophthalmology and being such a pioneer in the domain in Canada.
Well, thanks, Mona. I will say that this is, all of this is certainly not tied to me directly. There's dozens of other Canadian retina specialists who've been very, very, strong collaborators and have done more work than me and contributed more, but are certainly, I don't want to take any credit for doing too much, but we've had some successes in the little areas we've been able to influence, and it's been fun. That's been the best part about it. It's been fun and interesting, and we've all, I think, grown something together that's been I think a benefit more broadly than Canada too, which is important.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
Season 3 of the EyeCan podcast is brought to you by Bayer Ophthalmology. Thank you for your support.
Thank you to the Canadian Ophthalmological Society.
The EyeCan podcast is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.